And this is, such a fundamental part of our care for our diabetic patients. Every single person that comes to me for their first visit, I always ask them to go see a diabetic educator. Diabetic educators are gold. They are gold to me, because if I have someone, I always tell people, learning how to eat and the right things to eat, and learning about carbohydrates in our diet, learning how to read a nutrition label, that's more potent than the medicine that I can give them. And so at the first visit, I always try to take the opportunity to send my patients to a diabetic educator. And most of the time that's covered, in type 2 patients and type 1 patients. Just differing amounts of time is the difference, I think, between type 1 and type 2 in terms of what insurance allows payment for between the two, between type 1 and type 2 diabetes. So I do that initially, and then I always ask them to go back for medical nutrition therapy when their diets are uncontrolled. And if they're eating, high fried food, fatty foods, high carbohydrate diets, which a lot of patients do simply out of financial constraints or familial things or cultural, traditional. A lot of people have a tendency to just eat high carbohydrate meals. And so I think that lifestyle management, I can't stress that enough in having our patients see diabetic education. And then physical activity, we've talked about this in our slides, but having them do some kind of physical activity. Some people that, have never gone to a gym, I just try to say, in each community, there's usually a local, in Morgantown, we have a mall here. So, and the mall is open and it's heated. So I tell people, you don't necessarily have to go to a gym. Gyms can be intimidating. If you can just go to a local mall or a track, a high school, and walk, something is better than nothing. So that's where I start with my beginning points of physical activity. And some people are really limited, by their obesity and maybe arthritis. So I always consider, physical therapy and other modalities, or having their primary care assess them for, different modalities in pain medicine if that's a barrier to them being physically, active. And then smoking cessation counseling, we all try with that. Psychosocial care, I've mentioned before. Type 1 diabetes, there's a lot of literature on the psychosocial care. We really need to be aware of, type 1 diabetic patients unfortunately sustain much more mental illnesses alongside their type 1 diabetes diagnosis. So making sure that, if someone's not taking their insulin and they're depressed, making sure that we figure out what the barriers are, and if their mental health is precluding them from taking their insulin, then they need a referral to a psychologist or a psychiatrist to really help get past that so that they can learn how to care for themselves. You can move on to the next slide, Kate. So all patients with diabetes should participate in the diabetic self-education to facilitate their knowledge, skills, and their ability necessary for their self-care and self-management. And I had mentioned doing this at diagnosis, which I do this with all new patients that come see me. I do it annually when I see them. And then if there's any complicating factors that come up, so an example of this is, say we have our diabetic patient that unfortunately develops heart failure in addition to their diabetes, then they may need a low salt diet in addition to a low carbohydrate diet. And so times like that, you want to have them see diabetic education and have medical nutrition therapy, because balancing a diet that's low in salt and low in carbs is challenging. It's really overwhelming for a lot of people, especially when you're used to a diet that may be fast food all day. Some of our patients go to fast food for breakfast, lunch, and dinner. And so making sure that we actually teach them the right way to eat and the right things to eat is so important. And then when transition and care occur, that simply speaks to the fact that if you have, a young patient, say you have a young 18-year-old that's coming to you from their pediatric provider. You don't want to assume that they've had diabetic education and that they've had carb counting. You always want to, you know, dig deeper and see if they really understand how to count carbs, and offer them, you know, to go have self-education with an educator, because they may not have had that appropriately in their pediatric care. Maybe there was no diabetic educator at their pediatrician office, or maybe, you know, whatever circumstances limited them from getting the right education. So we can move along, Kate, to the next slide. So helping and facilitating these, we have just a referral in our system in Epic. I don't know how you guys manage it in your outpatient offices, but it's just part of our routine care here. It's just a simple referral. Again, should be patient-centered. I always tell patients that if they want to bring their family along to diabetic education, please do, because that really helps. So you can have it, you can have their family go with the patient, or there's other group sessions where they can go within a group where the diabetic educators in most areas offer free sessions weekly. I know in Morgantown we have Mon General and Ruby that offer weekly diabetes sessions. They're free. They're often in churches, church basements, that sort of thing. So if they go alone, if they go with family, or if they go in a group setting, however they go, we just hope that they eventually go and get the education. We can move along. So this was a little bit of trivia that I added in just to break up all of the slides. So I thought this was fun when I was setting up the ADA slides. So does anyone know what water tasters are? People who like different types of water, people who tested urine to see if it was sweet and attracted ants or flies, or people who tasted urine to check for diabetes. Any guesses? So this was people who tasted urine to check for diabetes, which I thought was pretty great. We're so lucky, right? Oh, gosh. So you can see there's a picture I put up of, you know, water tasters, that they would actually drink urine, because that is how they initially tested for diabetes. If it was sweet, they suspected the person had diabetes. Pretty gross, but it makes you thankful for the A1C, right? We can go on to the next one here. So our goals of nutrition therapy: support healthful eating patterns, maintaining body weight, blood glucose, blood pressure, and lipid goals, while addressing all of their individual issues, their access to healthful foods, cultural preferences like we talked about, and other factors. The plate method is a really useful planning guide to give guidance to your patients, and I have a picture of that coming up. But I'd like to speak to that a little bit, because I think understanding what each area's traditions are, you know, some people in different parts of the country like maybe fried chicken and biscuits. Some people maybe like French fries. Some people, the way that they eat all of their food is fried, and some people have, I told you, fast food patterns where they go out to eat with their family 3 times a day. And so understanding what each different person's habits are with their family and what their traditions are, I think really helps. And trying to explain to them that, you know, maybe some of those cultural traditions, is not that you have to let go of them. It's just that we probably should save those for maybe special occasions, and eating, you know, non-fried food and more lean meats and baked or steamed is the better way to go. So moving on to the next slide, talking a little bit about weight management. Any kind of lifestyle intervention program, we hope that there's frequent follow-up and making sure that we, you know, are checking their BMI when we see them, assessing if they're able to lose weight or the barriers of losing weight. Any weight loss is better than none, and it definitely helps and can delay the progression from pre-diabetes to overt diabetes. So I recommend any any and all weight loss, even 5 pounds, is incredibly helpful. Moving along. Major alcohol use. So I always try to screen for smoke. We said smoking earlier, but also alcohol use. There's no data on, how exactly alcohol affects our day-to-day blood sugars, but we do know that there are risks of hyper and hypoglycemia with alcohol use, especially a lot of the mixers that people put in their alcohol. So the juices, cranberry juice, apple juice, whatever, all those juices are loaded with sugar. So you can certainly have hypo and hyperglycemia with alcohol use. And I tell people to, be very careful. I don't recommend more than 1 drink a day for women and more than 2 for men. And if they are consuming alcohol, to really watch their blood sugar, especially type 1 diabetes, where, they're more prone to hypoglycemia. And it also, alcohol causes a lot of other deleterious things. So talking to them about consuming, excessive amounts of alcohol, I think is important. And I know, these are all things, again, that hopefully we can talk to our patients about over, the course of seeing them. This is very hard to address all of these things again in the very first visit, but I try to have a template of, my patients, and I try to put in the things that I need to really go into more in depth at future visits and the things that we've really covered. And then I just make notes of the things that really need worked on, or any kind of like red flag signals. And I just keep my type 2, I have a type 1 diabetes template and a type 2 diabetes template, and I just try to keep notes of the things we haven't discussed. So I get a lot of questions about non-nutritive sweeteners. You can move on to the next one, Kate. So I think, a lot of people ask me about these sweeteners, and I don't really have data on them. There are no randomized controlled clinical trials at this point in time that define the safety of them. So I tell people, if you use them, try to use them sparingly. I don't really know the long-term effects of these, but I do try to offer other solutions. There's a lot of new canisters where you can just make your own sweetened water, where you can put fruit in the middle. I don't know if you guys have seen those, but you can kind of marinate either fruit or cucumbers or something in water. So if people really want the taste, something different aside from water, I offer that. People ask me all the time about the Mio, and again, those have, they have the non-nutritive sweetener in there. So I really can't tell them the long-term effects, but I say if you're going to use it, just try to use it sparingly. So physical activity, the actual recommendation this is from the ADA, as are all of the recommendations and slides, but they say about 150 minutes or more moderate to vigorous intensity, at least 30 days a week, and no more than 2 days without activity. Adults with both type 1 and type 2 should have 2 to 3 sessions of resistance exercise or weightlifting on the non-consecutive days. And then all adults should decrease the amount of time spent sitting down or being sedentary. So you should always interrupt yourself every 30 minutes and make sure you get up and move around. And I think that's really important, because we have a lot of people, you don't really know until you go digging, but I have a lot of people who maybe spend a stretch of 6 to 8 hours sitting down. And whether that's at a computer doing work, or some people, unfortunately, is on their couch watching TV. And so making sure that we have people get up and get moving is super important. There are those new Fitbits and stuff that you can put on your wrist, or even using your phone to have an alarm that tells you, hey, I've been sitting down for 3 hours. It's time to get up and move around. And I tell people, if you're at work and in an office and you're limited by the amount of activity you can do, just go walk around your office. If there's a place in your office, or if there's stairs, it doesn't take a lot, just to stay active. Any amount of activity helps make you more sensitive to your insulin. So staying as active as possible is the goal. And then flexibility and balance training, those are great for anyone. You know, yoga and Tai Chi, they recommend, which I haven't seen those previously in the recommendations. I was happy to see that they're adding that in. And that helps balance and flexibility, especially in our geriatric patients. So moving along to exercise with any kind of complication of diabetes. So with retinopathy, if the person has proliferative retinopathy or it's very severe, then vigorous exercise is contraindicated because we could trigger a hemorrhage or detachment. And in those patients, I always have them see their ophthalmologist if they haven't and they're ready to start a vigorous program. And so typically, you know, with type 2 diabetes, they need to be seen once a year. With type 1 diabetes, the recommendation is that they're seen after 5 years of diagnosis and then yearly thereafter. So say that they've had their eye exam in August of last year and it was fine and they're not due for their next exam until August of next year and they're ready to start this intense program. I always send them just to make sure that things are okay before they start a rigorous program. Now, if they're just gonna walk or do something light, no problem. But I'm talking about if they're gonna go do like cycling and, you know, lifting, you just wanna make sure we're protecting their eyes. Next one, peripheral neuropathy. So if they have decreased pain sensitivity and a higher pain threshold, then they're not really going to feel the pain that can occur in their feet with really heavy exercising. And we all know that, you know, if you start running and you haven't run, you maybe develop blisters on your feet and it's painful. Or, you know, if you start biking, you know, even your behind can be really sore and painful. And so understanding that our patients may not feel those things like we do, and checking for rashes or ulcers or blisters that develop is really important. And, you know, if they have very severe peripheral neuropathy, maybe avoiding it altogether and doing something, you know, like swimming or, you know, not running or doing some form of exercise where it would traumatize or create ulcers or skin breakdown. Moving along. So autonomic neuropathy, this can definitely increase the risk of exercise-induced injury as well. These patients may have decreased cardiac responsiveness to their exercise and develop hypotension, impaired thermoregulation, impaired night vision due to their, you know, papillary reaction, and then a more susceptibility for hypoglycemia. So also assessing for that. And in the office, you know, you can just do orthostatic hypotension and check their blood pressure and their heart rate and see, you know, if they have any signs or symptoms of that. There's also an independent risk factor for cardiovascular death and a silent MI. So making sure that these patients, you know, have seen a cardiologist or their primary care doctor and kind of had an assessment before they start exercise as well. So I'm going to stop there. I have to run to the medical school at WVU here. I was just going to stop and ask if you guys had any specific questions that I could answer. No?
This is Dr. Gold. Do you mind taking a thyroid question?
No problem.
Okay. I have a 74-year-old male who had a 4-centimeter thyroid nodule on the right.
Okay.
Sent to ENT for fine needle biopsy, which came back negative. And he just wants to watch this thyroid mass. Mild echogenicity on ultrasound. And could you just give me some feedback of whether it's safe, even with a negative biopsy, to do this, or whether more aggressive therapies are indicated?
Does the patient have dysphagia, odynophagia, voice changes, or any compressive type symptoms from the nodule? it's rather large at 4 centimeter.
And it's a male. No, it's asymptomatic. It got picked up on, basically he had, the complicated comorbidity, he had a pulmonary embolus. And even though there was some thickening in his neck, he's a thick neck guy, it was more picked up incidentally.
Okay, so no compressive type symptoms.
Correct. And he's euthyroid.
Okay, and he doesn't have, on exam, well, I'm sure on exam you maybe not noticed, but you didn't assess whether he was like wheezing or had stridor or any difficult.
No.
Okay, so the first thing I always try to think of when the mass is that big is always, is it compressive? Is it narrowing his airway, and is he having dysphagia, dynaphagia, or voice changes because of it? Because that would be an immediate indication to have it removed without anything else. Okay, so then the size of it. If we think of a nodule, in the neck, can you guys see me?
I'm on cell phone.
Yeah, okay, so if you think of a nodule like a ball, when I do a biopsy, I'm only able to assess the anterior portion of that nodule, right? So I can't go through the superior portion, I can't get to the inferior, and I can't get to the posterior. For that reason, there's always the risk of a false negative, right?
Mm-hmm.
So the way that we try to follow these patients up is just after an FNA, I would recommend doing a thyroid ultrasound in 6 months' time to make sure there's no growth or change over time, because if it does grow, that's potentially a missed malignancy.
Right. Okay.
Yeah, and you said
so
thyroid,
it goes to ultrasound.
As long as he's euthyroid, it's definitely not, hypersecreting or hot nodule, which has a very low risk of malignancy to begin with. So he has this large nodule. It doesn't sound like it's compressive. You've already biopsied it. It's negative. So I would just tell him, if he develops compressive neck symptoms, to let you know. If he does, that would be an indication to see a thyroid surgeon. If he doesn't, you're completely fine just monitoring it with ultrasound. So ultrasound in 6 months from his FNA.
Okay.
And
Thank you.
Features, are calcifications, their increased vascularity or irregular borders, a nodule that's taller than wide simply because of the aggressiveness and how it grows within fascial planes, and the velocity of growth. So just kind of watching it, and we're always here. If you have more questions about it, we'll be doing echo, so you can always, if you do an ultrasound and things change, you can always let us know.
Thank you.
Sure. Okay. Well, thank you guys for your time.
Thank you, Dr. Giordano. I know you have to run, so we will see you later. Everybody, our next echo session is November 28th. So if you have any cases or anything like that, you'll be getting an email from me where you can submit them if you want to ask any questions. And please feel free to reach out if you want to hear a certain topic covered, if you want to have your question answered during the echo session. All right? Everybody have a wonderful Wednesday.